Hey guys, thanks for checking out my EKG interpretation course, Practical EKG Interpretation. This first episode is just going to cover the fundamentals or the basics of EKG interpretation. Now the first part to really cover is the cardiac conduction system. This is what we care about on EKGs. We're just measuring the electrical part of the heart. We're not really caring about blood flow. We're not looking for that kind of stuff. We're just caring about the electrical impulses. So when we look at the electrical conduction system, it starts with the SA node, and it travels down internodal pathways, which kind of go into the left atria, and they ultimately end up in the AV node. Down the AV node into the bundle of His and into our bundle branches. We have the right bundle branch, and we have the left bundle branch. Now the left also gets split into the left posterior fascicle and the left anterior fascicle. They're not really depicted on here other than this little blurb right here, but just keep in mind that the left bundle branch splits into two further branches, and the right really doesn't split into any other major branches that we measure. One concept I like to talk about, this is an analogy that I was taught in school that I think is very helpful. Pretend you're sitting at a bar and somebody, the bartender, hands you a beer and you want to pass it down to your friend way down at the other end of the bar. The fastest way to do this is to slide it down the bar to your friend. It gets there way quicker. The slower way to do this is to hand it from person to person all the way down the bar to your friend. The electrical conduction system is sliding that beer down to your friend. It's very fast, it's very efficient, but it's not the only way to get an impulse from one end of the heart to the other. If this system fails for any reason, for example, a bundle branch block, your impulse is getting here to your AV node quite quickly and then it stops right here. And it's still going to travel through the heart. It's still going to depolarize the rest of the heart muscle, but it's going to go much slower. It's going to be that beer getting handed from person to person all the way down to your friend at the end of the bar. So it's still going to travel here. It's just going to be much slower and inefficient. And I think it's kind of a nice analogy to think about it, because each cell in the heart can conduct these electrical impulses, but if it's not traveling via the electrical conduction pathways, it's much slower and inefficient. So the next big concept to cover is the electrical axis of the heart. And in the heart, you have a lot of positive and negatives. All these different vectors are going different directions in the heart. Parts of the heart are going very positive. Parts of the heart are very negative. And when you add up all these vectors together, you get the normal electrical axis of the heart, which is down and to the left at about positive 62 degrees. Now, when you look at different leads, for example, lead 2, you see that the waveforms are predominantly positive. And that's because when you look at lead 2, most of the vectors are traveling towards that lead, and it creates a positive deflection. A lead that's predominantly negative, such as V2 here, that means that most of the vectors are traveling away from that lead, and it just has to do with where they're placed on the body and where the vectors are. So predominantly positive waveforms like lead 2, everything's heading towards that lead. Predominantly negative leads like V2, the vectors are predominantly heading away from that lead, and that's what creates the positive and negative on these waveforms. One concept I want to cover here briefly, because it has to do with lead placement, is R wave progression. R wave progression is how the R waves are kind of positioned in your precordial leads, which is V1, V2, V3, V4, V5, and V6. In a normal R wave progression, you should start with predominantly negative deflections, and they should gradually transition. So mostly negative in V1, starting to get a little more positive deflection in V2, V3, they should be kind of positive and negative equally. And then you should start to transition to positive deflections in V4, V5, and V6. And that's normal R wave progression. And it makes sense because as you work your way around the body with those lead placements, you should have the vectors slowly transitioning to a different ultimate direction. So there's two different methods that I use to determine axis. I typically like the 3-lead method because it gives you a little bit more information, especially to determine a physiologic left axis from a pathologic left axis, but the 2-lead method works just as well. And the 2-lead method looks at lead 1 and AVF. If they're both positive, you have a normal downward to the left axis. If you have lead 1 is positive and AVF is negative, you have a pathologic left axis deviation. If you have both, or if lead 1 rather is negative, AVF is positive, you have a rightward axis, and if they're both negative, you have an extreme right axis. The 3-lead method is very similar, but it looks at 1, 2 in AVF, and it allows you to kind of distinguish a little bit more. If they're all positive, you have a normal axis. If you have positive and equivocal, meaning kind of equally positive and negative in lead 2, and negative, you have a physiologic left axis. If you have positive, 2 negatives, you have a pathologic left axis. And if you have negative, 2 positives, you have right axis. And if they're all negative, you have an extreme right axis. So here's an example of a pathologic left axis. The blue arrow indicates that we're at negative about 60 degrees rather than the positive 60 degrees. And one pathology that does that is a left anterior fascicular block. We'll talk about these more later in the criteria that defines them, but this is where the left anterior fascicle of your left bundle branch has a block in it, and this causes all the vectors to kind of add up to a slightly different direction. So we're now going up and to the left rather than down and to the left. Right axis deviation, this is an example of that. So instead of down and to the left, positive 60 degrees like we would be normally, something's happened with the conduction system and now we're positive about 60 degrees and we have an axis deviation to the right in this case. And you can see this reflected in the lead. So lead 1, if we use the 3-lead method, is predominantly negative. Lead 2 looks like it's predominantly negative, but it's a little bit hard to tell. And if we look at AVF, AVF looks like it's more positive. So you have negative, negative, positive. So that is a right axis deviation. And there's a lot of different things that can cause that. So this leads us into the normal sinus rhythm waveforms. So we start with a P wave. A P wave represents atrial depolarization. The impulse starts in the SA node, depolarizes the atria, and moves to the AV node. The PR segment is basically where the AV node is holding onto that impulse for a couple milliseconds. And then it travels down the bundle of His and into the ventricles and down into the bundle branches. And the QRS complex represents ventricular depolarization. It's much bigger because the ventricles are a bigger part of the heart. They create a bigger impulse. Then we have the ST segment followed by the T wave. The T wave is repolarization of all these cardiac cells getting ready to fire another impulse to the ventricles. And we don't get to see atrial repolarization because it's buried in the QRS complex, but that's basically when it would be happening. But it's a very small amplitude waveform, and so it just gets buried in the larger QRS complex. It can be a little bit confusing how they label the QRS complex. Basically, your first downward deflection is your Q wave. Your first positive deflection is your R wave, and a negative deflection that follows the R wave is your S wave. You don't have to have a Q wave to have an S wave. You don't have to have a Q wave to have an R wave. They all kind of work independently of each other. But if your first deflection is negative, that will always be called a Q wave. Your first positive deflection will always be called an R wave. And if you have a negative deflection following an R wave, it's always called an S wave. That gets a little bit overcomplicated, but I don't think that's something that really is important to focus on. Now, some of these intervals we really care about measuring. So the PR interval is one that I think is very important to know the normal duration of. And a normal PR interval is less than 0.2 seconds, which is one large box. We'll see that here a little bit later, exactly what that looks like. But that's a normal PR interval, and that's something we measure to look for AV blocks and a bunch of other stuff. So that one's important to know. Similarly, the QRS complex duration is very important to know, and it's usually less than 0.11 seconds, 0.12 seconds. And a wide QRS complex indicates a bunch of different stuff. It can be a different rhythm, it can be a bundle branch block. So that's another distance that's very important to know. Another important segment to know is the QT interval. And that's from the beginning of the Q wave, or the QRS complex, to the end of the T wave. And the normal duration of this is about 0.41 seconds. It's kind of considered prolonged if it's 0.419 seconds. And prolonged QT interval can indicate a few different things, but it really represents a predisposition to getting an R wave on top of a T wave phenomenon, which can cause torsades. We'll talk about torsades a little bit later. But it's important to note that because you don't want to give certain medications that can further prolong the QT interval. Another way to get a rough estimate of the QT interval is it should be less than half of the R to R segment. So we don't have a second QRS complex here to compare this with, but if we pretended it was right here at the end, the QT interval should be less than half of that distance. So that's kind of a way to get a rough estimate because it is a difficult thing to measure a lot of times. The last big thing I'll measure here is your J point, which is right where this cursor is. It's the very end of the QRS complex. It's the beginning of the ST segment, and it's where we care about measuring for ST elevation, which we'll get into later. But that's the last big point on this slide that I want to reiterate. So next, let's talk about all these little boxes that are on the EKG paper and what exactly they mean. So one little box, the duration and time is 0.04 seconds. So if you add up 5 of those, which is one of these larger boxes right here, it's 0.2 seconds. And that's the duration of time. And so of course you have one of these larger boxes equals 1 second. Now the amplitude of these boxes, the vertical axis, is 1 millimeter. And so of course you add up 5 of those, you get 5 millimeters. So this whole bigger box here is 1 full second in duration and 5 millimeters in amplitude. So when you add up all the little boxes on an EKG paper, a typical one of typical duration, you get a 10-second EKG strip. And it's important to know that when you're calculating the heart rate. So there's a couple different ways to calculate the heart rate. And a lot of times EKGs calculate this for you, but it's something you need to know how to do because they're not always super accurate. And the first method is just to count. You can count each QRS complex on the whole piece of paper. And in this example, we have 12. So you count all the way to 12. You know that each EKG paper is 10 seconds long. So you just multiply that number by 6 and you get 72 beats per minute, which would be a normal one. It is just by counting these moderate-sized boxes. And this method you use 300, 150, 100, and 75. This is a method I use usually for faster rates. It's a little bit harder the slower it gets. But in this case, you start at this QRS. I picked this one because it lands right on one of the boxes. Some of these other ones are a little bit off, but it's easier to start at one that lands right on a box. And you just count. So 300 to the first box, 150 to the next one, 100 to the next one, and 75 to the next one. And you can see this rate's just a little bit slower than the 75. And that gives you a really rough estimate of what the heart rate is. So we'll end this episode by talking about ectopy. And one of the biggest pieces of ectopy you'll see is PVCs, premature ventricular contractions. So this is where a contraction in the heart happens a little bit too early, down in the ventricles, before the SA node can recover and fire again. So instead of the SA node firing, you get something down here in the ventricles that fires before it has a chance to. And that's usually just because it's an irritable part of the heart for one reason or another. So here's an example of a PVC. So you have normal QRS complex with P waves before them. And then up here, before the P wave has a chance to fire, you have this big wide complex, and this is a PVC. We know it's a PVC because it's kind of wide and bizarre looking, and it comes before a normal sinus rhythm beat has the chance to kind of fire. The next type of ectopy that you'll see is premature atrial contraction. So just like a PVC is a premature contraction down in the ventricle, this is a premature contraction in the atria. So it can happen anywhere in the atria. And again, they fire before the SA node has a chance to recover and start a normal impulse. They just fire, and we'll take a look and see what those look like. These I think are a little bit more subtle, but if you just look at this whole rhythm strip, you can tell there's something irregular about it. So you have normal P wave QRS, normal P wave QRS, and then all of a sudden you have a P wave that looks different than the other ones, and it comes too early. So premature atrial contraction is usually starting with a different looking P wave because it's starting in a different part of the atria than the SA node, and then it goes down the normal conduction pathway. So you have a normal narrow QRS complex and a normal T wave because it's going down the normal electrical pathway. That's why it's not wide and bizarre. It's because it starts in a different place than the SA node, so a different looking P wave, but it travels down the normal electrical pathway. And lastly, a premature junctional contraction. These ones are a little bit more subtle and hard to differentiate sometimes, but there's something that starts somewhere in the junction or the bundle of His, and we'll take a look and see what those look like. So here's some examples of PJCs. I think the second rhythm strip's the better example. So you have, normal sinus rhythm, P wave, QRS, P wave, QRS, and then you get to this beat that comes a little bit too early, and there's no obvious P wave here, but it is a narrow complex. So it's originating somewhere in that bundle of His, but it's traveling down the normal bundle branches. It's a normal electrical pathway from there on, but it's clearly not originating in the SA node because there's no P wave. It's not originating in the atria because there's no P wave. But it's still narrow. So that's a pretty typical PJC. These ones up here I feel like are a little bit more hard to distinguish from PACs. These are still called PJCs, but they do have this little tiny weird looking P wave that runs right up against the QRS, and that's probably just because it starts somewhere higher in the bundle of His and then still travels down the normal electrical pathway. So PJCs are a little bit harder to distinguish from PACs. But this one down here I think is the better example to kind of distinguish between the two. So that's all I have for you guys on the fundamentals lecture. Watch this back a few times if you need to get some of these points reiterated. I hope this brought you guys some good value, hopefully helped you further understand or understand for the first time some of these concepts. Please give me feedback if you have it. Thanks.